With this, we'll go to our next session, going to be in approach to bifurcation lesion. I would like to invite my dear panelist with me, Dr. Haytham Amin from Bahrain, Dr. Habib Gamra from Tunis, Dr. Nabil Ismail, and Dr. Saleh Al-Ghadir. Dr. Ahmed Imam. So, because of time, we'll just go ahead with our first presentation. It's my pleasure to present Dr. Mohamed Sobhy. He's a well-known professor of cardiology and a great and expert interventional cardiology in the region. He will talk to us about bifurcation stenting step-by-step technique.
First of all, I'd like to thank GIS Group for inviting me. I was starting the GIS things at the beginning. I was asked to speak about step-by-step bifurcation. I know that I'm going to basic with the fellows here. How do bifurcation? Actually, this is a tailored approach that you have to stick on the anatomy, on the resource, and in evidence. Regarding the anatomy, step one, there are 3 A's before you say bifurcation PCR: assessment, anticipations, align. And you have 3 diameters of the vessels, including plaque length, distribution, bifurcation angle, and side branch ostium, and then planning with the bifurcations. To begin with, what's the complex bifurcation lesions? What's called true bifurcation, it's more than 50% lesion in both main branch and side branch, plus the burden of severe atheroma extending to more than 5 millimeters of the side branch ostium. The large side branch is more than 2 millimeters in diameter, supplying a large extent of viable mycoid. This is the complex bifurcation. Let's go into classification. This is the most popular. It's a Medina classification, including the proximal, a distal, and side branch. For example, if true bifurcation 111, it's for proximal and distal is 110. This is another classification which I don't like it. And then you come to the basic. How to measure with the 3 diameters. Finally, the Fennis law. It's 0.678 D1, which is the proximal, equal 0.678 D2, which is distal, plus the side branch is D3. So the 3 diameter, this is correct on the green line. This is not correct, equally D1 equal to 2. So what's the importance of plaque? Because this is the shearing forces of distinct atherosclerosis in the vessels, opposite the carina. The main defect is the carina. The coronary flow is recirculating, oscillating. It's called low shear stress. Carina is rarely involved. It's high intense shear stress. Important point in the decision of bifurcation is the angle, which sometimes it's missing by operators. Narrow angle less than 70, wide angle more than 70. The 3 parameters for this angle. Side branch wiring is easier with the narrow, difficult with the wide. Carina shift is more likely with the narrow, it's less likely with the wide. Side branch ostial coverage is difficult with the narrow, easier. Remember this. So let's go for step 2, what's the wiring and rewiring. Dilemma. Number 1, should a side branch routinely be wired? Can polymer-coated guide wires, coated guide wire be used for side branch protection? It's called jailed wires. And what's the correct technique for side branch wiring? Actually, this is the wiring. Upfront side branch wiring is recommended in true bifurcation or if difficult rewiring. Only main branch wiring be used if side branch angle is favorable and no severe disease. Don't wire the side branch. Only main branch is not recommended, side branch severe disease, unfavorably angulated. Step 3, pre-dilatation. Should side branch pre-dilatation be routinely performed? Evidence is post-stenting is better if side branch pre-dilatation is performed. A bit no difference in TIMI flow or clinical outcome. Should we routinely pre-dilate? This is only in 2 situations. In highly calcific lesion, and you have a 111 or 011 or 101 lesion with particularly difficult side branch axis. This is only you can routinely pre-dilate. How can you pre-dilate? The main branch pre-dilatation done for facilitation of the optimal main branch stenting and expansion. Side branch pre-dilatation if side branch flow is impaired, access difficult, and present severe calcified lesions. No routine side branch pre-dilatation recommended in provisional. Required. No, Gabriel is going to speak about provisional. No main branch pre-dilatation if soft plaque. It's almost always nowadays do pre-dilatation except if a soft plaque in the main branch. When performing side branch pre-dilatation, it's not recommended to use the same balloon. Not recommended to use the same balloon as the main branch pre-dilatation unless main branch and side branch diameters are comparable. This is very important. Step 4, main branch stenting. How to choose the diameter and length of main branch. The diameter should be sized according to the distal main branch. This is a lot of stents. You have to know the synergy, expedition, albine, resolute onyx, altimaster, biometrics, or serio. You have to know this completely different, but regarding the result, resolute onyx, this is for the extra large vessel is 4.5 to 5. DS is recommended approach in bifurcation PCI in main branch according to the distal vessels. If only BMS is available, it is may used for main branch stentings. Main branch stent optimization, how to correct perform POTS. Should kissing balloon inflation routinely be performed provisionally? Usually common questions. When can POT side POT used? POT is mainly used to correct proximal main branch malapposition. Routine kissing did not improve clinical endpoint in single stent strategy. POT side POT can be performed alternative kissing. How we can make it? This is the POT for the proximal optimal optimization. It's how to select. This is the Mary's law and proximal optimization technique. It's called POT, proximal optimization technique. As we can see here, for proximal optimization, this is used with non-compliant balloon, sized according to the proximal main vessels. As you can see here, the main vessels is a 5 millimeter non-compliant balloon. How to perform a final kissing? Balloon size according to the distal reference. Short balloons and non-compliant balloons. Side branch first, equal or 12 atmosphere versus 4 atmosphere. At least 20 to 30 seconds. Final single balloon of POT, it's called second POT, can be used. It's called POT, side dilatation and repot. POT, side POT. Kissing recommendation. Do you have a recommendation? Yes. It's optional for provisional. It's not routine. It is obligatory for complex. Side branch inflated first and simultaneous deflations. You have to use short balloons, non-compliant balloons, and long inflations. This is the example. POT should be routinely performed with short non-compliant balloon to correct for stent undersiding the proximal main branch. For kissing, 2 non-compliant balloons are recommended according to the side branch and distal main branch with short proximal overlap. As you can see here, short proximal overlap. POT side POT, doing POT in the main branch, could be considered as alternative to final kissing. And you can use semi-compliant balloon used for POT instead of non-compliant, if you can make it for POT side POT. Take into account the length of the stented main branch segment and maximum inflation size of the available semi-compliant versus non-compliant. It is not recommended to post-dilate the main branch stent distally because the carina would be a phase shifted with the balloon size according to the proximal main branch. Routine final kissing is not recommended in single stent stretch. This is the proximal optimization, and this is spot and then side pot. Then step number 6, side branch stenting. When can you make it? Which technique should be used if side branch stenting is decided? If the side branch is large, more than 2.5, and disease more than 5, upfront 2-stent stretch can be used better than single. Restenosis side branch less frequent with kilot versus tap, and crush better than kilot or even provisional. So when you do 2-stent strategy, large side branch more than 2.5 with osteal disease extending more than 5 millimeter from the carina are likely to require 2-stent strategy. Side branches whose access particularly challenging should be secured by stentings. This is the feature of the main branch, side branch. You have to make it, you have to look at the main branch for the atheroma burden with a local moderate extended, proximal diameter of the main branch, distal diameter, presence of calcium or not in order to make modifications of the calcium, and distal vessels whether lesion or atheroma. When you go to the side branch features, also atheroma burden, ostial, extended, proximal diameter more than 2.5 to less than 2, what's the myocardium at risk, the calcium and disturbance. These are the features when you're looking to your vessels to take a strategy, and then you look to the angle, more than 70, less than 70. This is from Colombo, through bifurcations, significant stenosis, the main branch. This is an old slide, but still we are using. If the significant stenosis in the main branches, no provisional stenting. And this is the talk of Gabriel. Yes, if side branch is suitable for stenting, yes, you can use it or no. If it is no, stent only the main branch and keep it open side branch. If yes, so it's locked to the side branch. If it is diffused, localized, within 5 millimeter. If no, only for provisional side branch. If yes, elective implantation. This is Dr. Mervat is going to speak about the techniques of this branch. Approach for this, if you have a very short proximal main branch, this is the only way to use the V-stenting. I don't recommend do V-stenting except in emergency, doing V-stenting. It's easy, but it is very high risk to restenosis. Either side, if the angle is more than 70, example 90, you have a use tap technique. If the angle is less than 70, you have either mini crush or decay crush or kilot. And also this is by Colombo. I'm not going into details, but this is an example of the tap. It's easy to perform. Internal crush, complete coverage, kilot, complete coverage, and Dr. Mervat is going to explain the details of this. Side branch stentings, if deemed. Tap also at 70, as I said, bifurcation angle less than 70, you have the decay crush and clots. Finally, what's about difficult side branch access, how to go in? It's very one that challenging is to wire the side branch. You have to have optimal working views to see the ostium. You have different patients. Guiding support is important. Sometimes you can use a microcatheters. Wire tip configuration is mandatory. Hydrophilic wires, don't be afraid of using hydrophilic wire. Pull-back maneuvers and coaxial balloon and microcath. This is how to manage the difficult side. This is an example of the standard wire for the wiring of the side branch. Then you saw what's anti-grade wire technique. Sometimes do wiring of the main branch, then pull-back wiring with a special curve to go on distal branch. And it's called this more curves called the reverse wire technique. And finally, the pull-back wiring. Then, Mr. Chairman, my colleagues, the conclusion of my talk, you should be aware of all bifurcation techniques, but be familiar with at least two. Medina classification is still the most popular. One stent is better than two-stent strategy. Lesion preparation, angle bifurcations, size of the side branch, ostial involvement side branch are the key choices of the technique and success of stenting. And thank you very much, and see you in next cardio, Alex.
Thank you very much, Prof. Sobhy. And I think we have a lot of presentations that have a lot of overlap together. So we'll make at the end the extensive discussion. But any points from our dear panelists before Dr. Sobhy leaves the podium?
Yeah, nice.
Dr. Gamra?
Thank you.
Yeah.
We can read today.
The question after at the end?
You can have one
Yeah,
question.
just wanted to ask you, I don't want to embarrass you with this question, Mohamed, but do you think that in 2022, we should pay attention to the strut cells or the thickness of the struts to have a successful bifurcation PCI?
Because you have a second, third generation of the stent, you mean? Because the struts differs from the old one. Sometimes difficult to beat the strut going to the ostium, sometimes very difficult to make it. But actually, after doing pot, it will be easier to. So I don't worry about the size of the stents. The stents size now, or the stent thickness now, I think it's very important now. We don't see stent thrombosis, for example, in the old one. So, and if you do a pot, it will be more or less resilient to open the struts in order to make it easy to side branch. When I use the second generation now, I found easy to have crossing of the side branch. So I agree about what you say.
Dr. Sobhy, thank you for this nice presentation. Just a quick question. How would you choose the right size for the kissing balloons without affecting the proximal part of the main vessel?
Actually, very good questions. If you have a stent, for example, side branch is 2.5, I'm using 2.5. I'm not thinking more for the side branch. But I go for the side branch. Usually when I'm doing kissing, I'm doing first alternating. The side branch first, then then the main, and then alternating. And then finally I go out with the side branch to the main vessels and doing with a higher pressure. For example, not more 20, 22, and then ending by 216, for example, for the main branch, side branch.
Great. Thank you very much, Dr. Sobhy. And with this